Another fun day at Beck, the best theme park in Southern California. We are delighted to welcome Dr. Katie Karlsgodt here to our department today. And she is, I would say, the truest Bruin among us. She did her PhD here at UCLA. She did her postdoc here at UCLA in the Semel Institute. And is now an associate professor in clinical psychology and has a secondary appointment in psychiatry also at the Semel Institute. And her work is in cognitive neuroscience. I learned that she even worked at the hospital where I was born 1 second ago, so that's cool. And so very excited to hear about her work. So without further ado, Dr. Karlsgodt, thank you.
Hi, well, thanks so much for having me. I'm excited to get to share some of what we've been up to over in psychology. Adolescence is this really interesting time of your life. There's a lot of cognitive changes, social changes. It's a time when you're becoming an adult. But one thing that's really interesting is that your brain is actually, it's at its full volume by the time you're 10 or 12 years old. Obviously, 10 or 12-year-olds are not acting like adults, so more has to happen. But in terms of overall size, it kind of peaks out at that point. And what's happening inside, kind of under the hood, is a lot of structural and functional reorganization that supports some of these changes that make this 10 or 12-year-old into an adult. So two changes that are happening are in gray matter and in white matter. And in the gray matter, which is, let's see, this, there, and like there along the edge, you have this normal process where the gray matter gets thinner. And it's getting thinner. It sounds bad that it's getting thinner, but it's not. It's important because you have a lot of extra synapses as a kid, and you start to get rid of the ones that are extra, that are redundant, that are not well connected. And the result is a more efficient brain. You don't want to have to spend energy maintaining all of those non-useful synapses. At the same time, the white matter is increasing. And the white matter is the connection between different brain regions. And each of the little axons that goes along to connect different brain regions is insulated with this fatty covering, kind of like the covering on a telephone wire, that makes it carry information more efficiently. So both changes are aimed at getting your brain to be more efficient. But these changes don't happen just all at the same time. Your white matter tracks actually myelinate across your early life. So it starts when you're a fetus with motor and sensory things because it's important to get these basic functions up and running as early as possible. And then there's other tracks that kind of continue across your early life. And then these higher level association tracks are the things that support higher level cognitive function. And they do not finish maturing until up here in like your 20s. So that's why some of these some more complex functions don't really come all the way online until later, because the network supporting them is still developing. One higher level cognitive function that gets a lot of attention is decision making. So this is one of the things that continues to mature across adolescence. There's been a lot of research on this. There's negative outcomes can happen if you make a non-optimal decision, like these three young men who've opted to cliff dive backwards off of this rock, which is probably not optimal. So when you're making a decision, you have to think about all the things that are in front of you as a choice. They have the choice to jump off, they have the choice to stay on the rock, they have the choice to go home. You weigh the cost and reward of each one. For them, maybe the excitement of their peers was one of their rewards, the adrenaline was a reward, the accomplishment, and then you choose what you're going to do. We see heightened rates of risky decisions in adolescence, which can then impact real behaviors like use of substances, driving fast, all these things I've talked about. And these sort of negative aspects of risky decisions are what get the most attention. But it's really important to remember that risk-taking is not actually all negative. especially in adolescence. So risk-taking can also look like doing extra exploration, which we see in adolescence. It can look like doing something like this guy who's leaving for college. That's a big risk. He's leaving his home, he's establishing himself as independent. This girl's having to try to find a friend on the first day of school. She's protecting her friend from a bully. All of those things involve risks, but we consider them to be like adaptive risks. So there are, benefits to engaging in this risk, and it's maybe not as, the downsides aren't as dire. And this kind of risk taking is really important. And when we think about psychopathology, we're going to talk about it a lot, we want to think about, we don't want people engaging in bad risks where you're, doing too many drugs or things like that. But you do want people to do this kind of stuff because that's an important part of growth. And adolescence is really a time of learning and exploration. And a lot of the learning that's happening during this period is social. And to support this period of enhanced learning, adolescents are sort of by design more sensitive to feedback. So they are more sensitive to positive and negative feedback, which makes it easier for them to rapidly learn things, for instance, from their peers or from their environment. And what we'll talk about today is that in certain populations with mental illness, there are disruptions in this reward sensitivity, this normative reward sensitivity. So there may be people, for instance, who have the symptom anhedonia, which we'll talk a lot about, who are less sensitive to some of this feedback. And we actually know very little about, we know sort of like in adults that these disruptions can happen, and we know in adolescence this is what should be happening. But what happens in, say, like a youth with psychosis who's having some of these symptoms that differentiate their experience, we don't know as much about that. And it's important because in addition to being a time of exploration and learning, adolescence is also the time of onset for many major mental disorders. And it's kind of become part of our understanding to the extent that schizophrenia gets described as a developmental disorder. But it doesn't mean it in the way that you often think about it, where you have a little kid getting a disorder. It's a disorder that emerges across particular stages of brain and cognitive development. So in this case, it's emerging across adolescence. And it makes it complicated because that means that all of the psychopathology and all of the brain changes we associate with the disorder are also happening against the background of these other normative changes. And initially you might think like that is just makes it too complicated and not do it. But I think it actually is important because there's a lot of opportunities there for intervention. So if we know the brain is extra plastic or undergoing a lot of changes, and if we know all these social relationships and learning are happening and they're wired for that, then it might be possible that this would be a special time in the lifespan in which you could potentially have different interventions that would work differently than later in life. So my research is primarily on schizophrenia, just to get us all on the same page with that. The word schizophrenia means split mind, which does not mean what it means in like popular media, which is multiple personalities or two identities or something like that. It just means that there's things like cognition and emotion and perception that normally are sort of coordinated and can work together. And in schizophrenia, something happens and they're not as coordinated as they could be. And that leads to sort of this splintering from the reality that other people are experiencing. It's about 1% of the population, and the primary symptoms are divided into positive and negative. So positive doesn't mean good here, it just means the addition of a behavior onto typical behavior. So you're adding here delusions, hallucinations, disorganization. And the negative symptoms are taking something away from typical behavior. So avolition, like a lack of motivation, apathy, withdrawal, less speech, less emotional, sort of back and forth, and anhedonia, which is a not taking pleasure in the things that you used to get enjoyment from. And we'll talk in a minute about the onset. So the onset, the peak age is between 15 and 25, and you can see here, this graph, that it's starting to really ramp up. What's important about that is a big chunk of people have their onset while they're still teenagers. And we kind of don't think about that as often. Oftentimes when people think about the group of patients who fully have a psychotic disorder, they kind of lump them in with the adults. But there's a big group of people whose experience of adolescence and experience of psychosis are overlapping. And it matters because these patients have a much longer duration of untreated psychosis. People aren't maybe looking for it as much and noticing it as much. And duration of untreated psychosis is actually really correlated with outcome. Like how quickly you get intervention is associated with how well you do in the end. But very little research focuses on these patients as adolescents. Their diagnosis is less sort of differentiated, like symptoms sort of are maybe still coming in, so maybe you start with like a mood disorder with psychosis, and then you have some affective disorder, so there's a little bit less stability in these patients. And overall, the outcome is worse, and we don't really know why. So other main background is just this idea that in medicine and in health, we understand now that there's not just no disorder and disorder. So like we will happily say that you don't just have perfect blood pressure and then high blood pressure. There's degrees of it, how much you're impacted, and the same with diabetes. And it's true for mental illness. There's some people who just have low-level symptoms, kind of varying down here, and some people with full-on disorders. And I think like the autism community's done a really good job of kind of making people comfortable with that and explaining the spectrum of autism, and people are very comfortable saying things like, I'm just kind of generally a little bit anxious, or something like that. But schizophrenia is also on a spectrum, just like all those things, and people don't talk about that as much. I don't think I've ever heard anyone talk about this outside of conferences, basically, or the labs that I do. But there are people, we'll talk about what that looks like, who just have low levels of some of these symptoms the same way someone could have a little bit of social deficits on the low end of the autism spectrum or a little bit of insulin resistance. And doesn't get a lot of attention. So what could spectrums in psychosis look like? In the lower end, which would be kind of like our insulin resistant type end, you have what we call psychotic-like experiences, and we'll have a couple of studies we're going to look at with those. And that is just like, really just, you're not broken from reality, it's just a little different for you. So you're not having full-on paranoid delusions, but you're maybe more suspicious than your friends are in the same situation. You don't have full hallucinations, but maybe you see things out of the corner of your eye, and you're not totally sure if they're real. Maybe quirky, you're a little quirky. But this is not usually a treatment-seeking person. This is just kind of like, can be the way people are. And there's, nothing wrong with that. A little more severe, maybe like the pre-diabetes phase here, is like the clinical high-risk state, where it's a little more severe. Your symptoms are almost at the level of being diagnosable, but they're either just slightly too low or they're not frequent enough. And often this group will be noticing their symptoms, other people will be noticing them, and they will be often referred to some kind of treatment. So that's one kind of spectrum within the illness. There's also spectrums between illnesses. So some of the symptoms we'll talk about today can be present across more than one kind of mental illness. So symptoms that we commonly associated with mood, like depressed mood, could be there in schizophrenia. It might be more prevalent in major depressive disorder. Anhedonia, like the loss of pleasure, is present across all these things. So we can have spectrums within a disorder, and we can have spectrums between disorders with symptoms that vary across them. We'll talk mostly about spectrums within the disorder. And in adolescence, when people, you can see here the onset of like lower level schizophrenia spectrum symptom does start earlier. And I actually showed with some data from the hospital where Molly was born that there's a peak in these type of symptoms in adolescence. And this is just in typically developing adolescence. Just increase something about what your brain is doing makes it more likely that you're going to experience these things. And then finally, when we talk about negative symptoms, they do span across many of these diagnoses. They're kind of transdiagnostic, like at the bottom spectrum between disorders, are often associated with dysfunction and reward processes. They're associated with poorer outcome, and patients who have adolescent onset psychosis have more of them. Outside of diagnosed populations, many of these symptoms just vary in like a trait-like way in the general population. So people just vary on like how much they enjoy things or like how much they socialize, things like that. And that can be very normative, but it can also be interesting looking at what correlates with that normal variability. So we're going to look at some recent work from my lab, and one of my key questions is what happens to the brain and different aspects of development in youth who have psychosis, and why is the outcome worse, and what can we do to kind of help predict that? So one hypothesis, this is sort of just like one piece of the lab's work we'll be talking about, but if there's more negative symptoms in adolescent onset psychosis, and we know adolescent onset psychosis has worse outcome and the negative symptoms have worse outcome, one reason for that might be that you're expected to do all this reward-related learning and learn from all this feedback and learn to function socially and things like that. And it might be that having these symptoms, particularly during adolescence, is impactful for your outcome. So it's bad to have them later, but it's extra bad to have them interfering with this learning that happens in the middle of adolescence. So, and that may be true also for youth who have high anhedonia. They may also ultimately have less optimal outcomes because of this. So the idea would be that you can have increased negative symptoms will lead to less exploration and less risk-taking in adolescence, which is normative, which then you have less opportunities for the social learning and you may be differently responsive to that feedback you're getting, so you're just less good at the social learning, and then your outcome is worse. So we'll look at some studies that kind of go along this pipeline. So first in reward, I want to acknowledge that reward is very complex and we're only going to be talking about a few aspects of it here. So we'll mostly be talking about reinforcement learning and decision making, but we were remiss to imply that that's all that there is to reward function. So the task we're going to look at here is a reinforcement learning task. And it was actually gathered in a big study that I was working on during my postdoc at the Semel Institute, but that's now publicly available. There's about 1,000, a little more than 1,000 controls, and then 50 each of schizophrenia, major depressive disorder, and ADHD. We're just talking about schizophrenia. And they did this task, we're focusing on this part of the data, where they're shown pairs of stimuli, and the stimuli have different probabilities of being rewarded. So maybe this one has an 80% chance of being rewarded, this one has a 20% chance of being rewarded. And you have a lot of trials where you're learning the relationships between these stimuli. And when we watch you learning about that, we can see how well you end up doing at picking the more rewarding stimuli that you get a bigger amount of reward for. But we can see things like how responsive are you to positive and negative feedback. So when you get one wrong, do you immediately stop doing that and start doing something else, even though maybe that stimuli had an 80% chance of being rewarded and it was probably just a one-off that you didn't get the reward? Are you shifting immediately, or are you going to give it more chances? Or when you get positive feedback, to immediately shift to what the positive feedback would relate to. So you can kind of pull these things from this task. This is work by my student Pooja, who's just graduated and is now a postdoc at the VA with Michael Green. And the first thing we see in the CMP is adults. So when you look at learning from positive feedback, we're not going to pay attention to bipolar disorder because we're just talking about schizophrenia today. But the patients learn less well from the positive feedback. So they're paired in that area. And this is value updating after positive feedback. So that's basically like you're maintaining this representation of the value of different items that you're choosing between. And when you get feedback, that should inform your representation of that and how well are you using that. And here, they're not as good at using positive feedback to update their information. So they're generally not doing well with the positive feedback. At the group level, actually, their negative feedback learning was intact. But at the group level, positive feedback learning was impaired. However, we're also interested in negative symptoms. And to do that, we have to look sort of within the patient group. Because schizophrenia is very variable, it's very heterogeneous. There's very different symptom profiles in different patients. One might have a lot of negative symptoms and one might not have very many. It can vary a lot. So it's relevant to know, like within the group of people with schizophrenia, what are the differences? So here we see that in people with higher negative symptoms, they had worse updating after positive feedback. And actually, even though at the group level they didn't matter, when you look specifically at positive symptoms, their negative feedback updating was lower as well. So they're doing less well incorporating this different feedback, which leads to doing less well at learning. The next task we use is called the balloon analog risk task. Now, everyone always likes doing this task. The reinforcement learning task is not fun to do. It's like a million trials of learning the probabilities of these different fractals. This one, you inflate this balloon, and each time I'm inflating it, I have the choice to inflate it or to cash out, and at some point it pops. And in our version of the BART, we have two balloons. One is really likely to pop, and one is not. It's has a low likelihood. So we can look at a lot of different things with this pretty simple task. You can look at total inflations. You can look at how fast you figured out that they're different. You can look at how consistently you apply that information. And then we've gotten recently really interested in this low-risk balloon because there's a lot of room to explore in the low-risk balloon. It's not as likely to pop. So you actually have the opportunity, if you're willing to take a little bit of risk, to get a lot of points in that condition. The high-risk balloon is probably going to pop, so you don't want to use that chance to try to get a lot of points. We also look at, after you pop a balloon, what do? Do you completely panic and stop inflating at all? Or are you impervious to this information and you keep going? What happens? So this is a second study from Pooja's dissertation that we're going to submit. This is a sample that I recruited at the Feinstein Institute in New York. A youth with psychosis spectrum disorders. And the first thing we saw was here, we have high risk and low risk, and there was no difference between groups. Everyone could figure out that the high risk was pretty likely to pop and the low risk was not, because they inflated the low risk balloon less than the high risk balloon. So that's good, because we can't make assumptions about them taking adaptive risks and exploring in the low risk context if they don't know it's a low risk context. But everyone's able to figure that out pretty much. But then when you look at how that relates to a negative symptom, here she used avolition, which is kind of like a lack of motivation, sort of, lack of, getting up doing things. Here, the people who had higher on this negative symptom had less inflations. So they're less taking advantage of this opportunity to get these points. And same is true with the post-explosion. So taken together, we can see that there is some evidence from this data that the people with more negative symptoms are not exploring as much. They're not learning as well in the context of the reward learning. They're having more trouble using the feedback that they're getting. So that is holding up in the initial data. We looked at social function. This is work from my student Logan, who's currently in his internship year. And this is data from another one of these large samples. This one's called the Human Connectome Project. and it's also about 1,000 just community adults not selected for any kind of diagnosis, and they have a measure of subclinical psychosis in it. I think the existence of these big data sets is actually part of what has led a recent increase in looking at subclinical symptoms, because basically it was very hard to do it before, because you'd have to either recruit specifically for them or just hope you got some people, but then you have these giant data sets and there's no patients in there, so you can't really look at that, but you're interested in psychosis, or you get to look at psychosis. So he was looking at the fact that people with subclinical psychosis have social deficits just like people with schizophrenia do. And usually people are looking at objective measures of that. So like, how many friends do you have? How many outings do you go on? Things like that. And then less often people are looking at subjective things. So here he's looking at loneliness. So this is kind of interesting because people with schizophrenia do socially withdraw, and you might initially think like, oh, they don't want the socialization at all. Like they weren't interested in that. But they're reporting loneliness, at all the levels that we've looked at on the spectrum. They're reporting loneliness, and that has impacts on physical health, mental health, outcome. So it's important to understand why. So here we looked at psychotic-like experiences predicting loneliness, but what might be causing that? So first was a relationship with anxiety and depression. So there's one path where psychotic-like experiences predicting loneliness go because of a relationship with anxiety and depression. Separately from that, there was a path through emotion processing. And this is sort of like your efficiency of identifying emotional states. And this also mediated it. And what's interesting about that is, you look further, the people with psychotic-like experiences had trouble with, like efficiently processing emotions, which was then related to them sort of misunderstanding things and like perceiving experiences of rejection, which then led to loneliness. And you can imagine that these would be some of these key things that you're supposed to be learning about in adolescence. You're supposed to be learning about, like, how do I recognize complex emotions? How do I tell, like, if that person's complex emotion means, what does it mean about how they feel about me? And all these, like, things you have to figure out, and this makes adolescence hard because you're learning all that. So they're not able to do that even as adults here, the subclinical psychosis. And if you look at that same task, this emotion processing task, it's a really common task that's being used. And it was also used in this big neurodevelopmental cohort. So we can see that, reaction time is really increasing in this task across adolescence. This goes up to like 25, and they're still increasing. So it does seem like this is one of these things that you would normally be kind of learning here, and if they're having some kind of impairment in learning about this, understanding these emotions, that then leads them to be impaired in that, and then leads them to have these sort of like misattributions and misunderstandings about what people are doing. You can see how that pipeline could lead to this non-optimal outcome of loneliness. But we still have to directly explore this in the adolescence. So then we present a little bit of data from our student population. So UCLA has 31,000 students, and in the psychology department we have more people than went to my college. So it's a very large major, and demographically it's basically matched, requested all the demographics, and it's very similar. It's just that in psychology there's 70% males, which is pretty typical for a psychology department. And we have this system where in the introductory psych class, anyone in psychology can submit up to 18 questions, and they will administer it to all. There's about 500 people in each instance across the year of intro psych. And you can give them these like screener questions and then invite them back based on whatever you have asked them about. So we screened many people for subclinical psychosis related questions. Should also note that because it's intro psych, it's actually a really popular class, so it's not all psychology majors. There's pretty good representation from other majors for people just trying to take like a general class. So the first thing we wanted to know in this group is are we recruiting people who just sort of randomly replied to things and it means nothing, or does it look like what it should look like? And so we recruited this group based on positive symptoms, because that's what we were looking at the time. And it correlates with negative symptoms. And you would expect that if this is a real thing, that they would be kind of hanging together like that. So it doesn't seem completely random. It seems like it's hanging together the way it does in other subclinical psychosis populations. And you also want to know that it's not just the way they felt that day. So when you look across follow-up, there's actually a very high relationship between baseline symptoms and follow-up positive symptoms. I don't have negative symptoms here, but it's also highly correlated. So it seems like what they're reporting is something that's a consistent trait about themselves. It's not just something that goes way on that day. The other thing we want to know is whether these participants are having sort of similar problems to things we see in other areas. So we see in youth who have psychotic spectrum disorders a number of cognitive deficits. My old postdoc, Catherine Haggerty. And in particular, we see a lot of executive function problems. So problems like organizing, keeping track of things, inhibiting things, are all often impaired. So we looked at that in our sample as well, and we saw this previous undergrad in my lab, Lee Fan, did a lot of research in this, did a lot of these analyses for her project. And we saw that both positive and negative symptoms were very correlated with the amount of dysfunction, executive dysfunction. So this measure measures things in different domains, like having trouble keeping track of things, having trouble staying in your seat, having trouble, not saying everything you're thinking of. So it's different than the previous slide, which was more of like a lab-based cognitive measure, but this is showing that even in this population of UCLA undergrads who are typically pretty highly functioning, there still are these cognitive differences here that we're seeing in them, or behavioral differences. So then we looked at social support, and we used this measure called the ISIL, which measures sort of your appraisal of social support, how you perceive your social support, your feelings of belonging, and then tangible social support. Tangible social support is like, if you had a movie you wanted to see, how hard would it be to find someone you wanted to go with, that kind of thing. And across all of them, the people who have more negative symptoms, again, have more of these social deficits. And it actually persisted, so, it's a longitudinal follow-up study, and not everybody is interested in coming back. So we have a pretty small follow-up group currently, but it turns out that the negative symptoms at baseline predict also your social functioning later. So it's not just sort of in the moment, you're having like a mood difference that's changing how much you socialize. Like there seems to be something actually different. So this kind of supports more of this relationship. So not only are these negative symptoms impacting the exploration and risk-taking and opportunities for learning here, they're also impacting the social learning, as we saw with Logan's work, based on their processing of the emotions and the perceived rejection, and then impacting functional outcomes like loneliness and lack of tangible social support. So some future directions based on all this One is we're ramping up a study in undergraduates right now where we're going to recruit, this time based on subclinical negative symptoms, and specifically sort of like to look at some of these things all together in one study instead of piecing it together across studies. Measure reinforcement learning and risk taking, and using geo-tracking. Also, this is my acronym I'm most proud of because it actually spelled a word that was related to the study, which almost never happens to me. If you're good at acronyms, let me know. And use ecological momentary assessment to ask them questions about their real life responses to positive and negative events. So people do things like you ask them about events that are happening and you see like something negative happen, like how long are you impacted by that negative thing that happened? How long are you impacted to that positive thing that happened? So not only like on a task, how are you responding to feedback, but in your daily life, how does that kind of feedback impact you? And then look at social function as a kind of outcome. And then sort of in the planning part, collaboration with Carrie, who just walked in as like collaborator for the adolescent psychosis stuff here. Looking longitudinally in the youth with actual psychosis, looking at negative symptoms, and then looking at that question of whether there are these impairments in reinforcement learning in this population, and whether the relationship between your negative symptoms when you come in and your function at the end is impacted by this intermediate negative problems with learning. So are you really like start losing this opportunity that that healthy adolescents have to do all this reward and social learning, and is that the reason you have a problem? So why does it matter? It's because we don't know why adolescents with psychosis are doing worse later on. They have worse outcomes and we can't predict it or understand the mechanism for it. And there may be special risk to having these symptoms during adolescence. And if that was the case, it might be that there's some way that you could get in there and sort of try to improve learning processes or look at specific networks that are changing and see if there's some way to impact things or train them. So as I mentioned at the very beginning, there's the complication of having youth who have these symptoms at the same time as typical development, but there also is this opportunity to leverage the change that's happening to, try to help. And so I acknowledge my collaborators in my lab, and funding sources and all that.